Hello, everybody, and welcome to Hugh's Clues Hemodynamic Principles, Part 1. Hemodynamics is kind of a difficult topic and a little bit hard sometimes for students to grasp. I'm going to try and make it as easy as possible because, of course, it does have quite a few questions on the exam. And so we're going to talk about the principles of it first, and then what I'll do is do some clinical applications so you can know how to apply this in the clinical setting. When we talk about hemodynamic monitoring, the fancy definition is the measurement of pressure flow and oxygenation within the cardiovascular system. And there is a document in your clinical packet or somewhere in your Blackboard notes that talks about what are the nursing considerations for hemodynamic monitoring. And there's usually 2 or 3 questions on this on the exam, and so of course it would behoove you to look over that document. Now, before we begin to talk about hemodynamic principles, it's important that you understand the flow of blood, because if you don't get the flow of blood, if you don't remember from A&P, and I'm always surprised, you guys sleep since A&P, and so you do forget, then you need to spend a little bit more time on this slide, because you've got to know not only that blood will flow from the right inferior and superior vena cava through the right atrium, through the valve, tricuspid valve, in through the ventricle, out through the pulmonic valve, into the pulmonary artery, and so on and so on. So you've got to know the valves, you've got to know the chambers, and you've got to know the flow of blood direction. When we talk about hemodynamics, we really have to talk about, again, go back to A and P. So what I say to you guys is just close your eyes and imagine that you're standing at the edge of the pond, and in your hand is this very, very heavy rock. And so if you threw that rock into the pond, you can see what I have pictured here is that that rock will make ripples, and those ripples will begin at the core, at the center where the rock was thrown, and then it will fan out. And that's really how arterial blood moves through the artery. As soon as the left ventricle ejects it into the aorta, it causes this wave of blood that then moves down from the aorta throughout all the arteries, and that's how oxygen is, of course, delivered to all the tissues in the body. So how would you, the nurse, assess this wave of blood that's moving through the arteries? Now, students often say it's the blood pressure. Well, that is not true. It is the pulse. The pulse that you feel, your patient's pulse, is you are feeling that wave of blood every time the ventricle ejects blood into the aorta. You're feeling that wave of blood. And I have kind of a silly little YouTube video that's about dominoes. If you line up a bunch of dominoes and you move them, you can see that wave. And that's really how blood moves through the artery. It's in this wave. You know that this wave of blood is moving because you can feel for a pulse. Well, let's talk about patients. How is this applicable to a patient scenario? Well, we know that blood moves in a wave throughout the arteries. And if, for instance, we want to measure the arterial blood pressure, not just one measurement with the non-invasive cuff, but a continual measurement, because the patient's blood pressure is 80/40 and we want to watch their blood pressure continuously, a physician can insert a catheter into the artery. Now remember, you're going to have to remember which blood vessel this catheter goes in. This catheter will go in an artery, an arterial catheter. And we can, with this arterial catheter, we can constantly or continuously measure the arterial blood pressure. And what is happening is, that for each catheter that's inserted, there is a hole. And this, as blood moves through the artery, that wave of blood can transmit. And I'll show you some more things in just a second on the next slide. For right now, what you need to know is that an arterial catheter can be inserted by a physician into an artery, and it can be connected to tubing and some other devices, and we can measure or we can see the arterial waveform and watch or assess the arterial blood pressure continuously. What else could we use the arterial catheters for? Well, because we could sample blood from it. We could get ABGs and glucose and electrolytes from the arterial catheter. So how does it work? Or no, here this picture is where would we insert it? So the first place or the most common place that's inserted is the radial artery. And you can see here, again, it's very important for you as the assessing nurse that you realize when you see a catheter, is this in the artery or is it in the vein? And so that's part of your assessment to identify what space is that catheter in? So this particular catheter is in the radial artery. It can also be placed in the femoral artery. It's usually a longer catheter because this femoral artery is bigger, and because the patients can bend their leg and kink the catheter, so the catheter device looks a little bit differently, but it's still the same. It's in an artery. And there are times when it can be in the brachial artery too. You may see it in the brachial artery. Those are the most common, in the femoral and in the radial. Now, how does this arterial catheter, how does it measure, or how is it able to relay the arterial pressure to us? So again, we know that the catheter has a hole in it. And if there's a hole, then that wave, just like you see how it moves outward, well, that wave can move outward through the catheter hole, and then we connect it to this pressure tubing. So it's special pressure tubing. Now, you know, as all tubing, when it's hung, we prime it. We prime it with saline. So if you think about it, if you were on let's say you were on a platform and you jumped up and down. Well, that's like the arterial wave. You would feel that vibration. And so that's what this tubing does. The vibration or the wave will move up. It's a physics thing. Will move up through the hole in the catheter, up through the normal saline that's in the tubing, and it will move up, move up, move up to this device. And this device is called a transducer. I call it a translator because it translates that vibration into a wave that is then visualized on the monitor. And you can see with this that you see the wave, but the transducer will also provide us with the numerical value, because we need to have a numerical value. That's what we're going to document as we see this wave. And of course, there are some characteristics to the wave. That's not important for you at this point in time. But know that, yes, there are specific characteristics of the wave that also identifies. You can also see that the wave is colored in red, and this is a common color that is used on the monitors, so that as I walk down a hallway, I know that the patient has an arterial waveform because the wave is in red. And this is how we can monitor the continuous arterial blood pressure. You'll see this little gizmo. This is a pressure bag that we inflate. What this does is it ensures that arterial blood, because it is under pressure, does not back into the tubing. So there is pressure on this bag that's pushing down, and that will help keep the blood, arterial blood that's under pressure, from forcefully getting into the tubing. You and I both know that we don't want blood sitting in any kind of tubing, because then there's a risk of clots. And so we want to ensure that this line is clear of all blood. And when this pressure bag is inflated, then it will also allow a few drops of saline to continuously go through that arterial catheter, so that there isn't a clot that's formed on the end of the catheter. Hopefully your instructor will be able to show you this during your clinical visits, so that you can actually see this, because it's very hard to describe, and it's very hard to get imagine what this would look like if you've never seen it before, and I'm just describing it to you on a stationary picture. So get your instructor to help you visualize this, or try and go in the room of a patient that has the pressure bag and an arterial catheter. Again, email me anytime you have any questions. So let's talk about, you're going to see the numerical value of the blood pressure. So what would you expect to see if the patient's blood pressure was low, or what would you expect to see if the patient's blood pressure was high? Well, obviously a low blood pressure is going to mean that there's a very weak wave that is moving through the arterial system. So you would see a very low pressure. But again, we don't document low pressure. We document the numerical value that that transducer or translator actually puts up on the monitor. So if the pressure was 80 over 40, the wave would be very low because it's a very weak wave. And then if the pressure was 180 over 110, you would see a very high wave because that's showing you that there is a lot of force that's going through that artery. Now, one of the things that we know in any time that there's translation or that there's a translator, whether it's English to Spanish or Spanish to English, is that we want the translator, we want the transducer to be accurate. You guys know the saying, garbage in, garbage out. If the transducer is not um, or if there is not an assurance that the transducer is giving us the correct information, then we're going to get wrong information on the screen, which means that there could be wrong information relayed to the physician and an incorrect treatment. So the nurse has to ensure, it's the nurse's job. There's not going to be an order that says do these things to ensure accuracy. The nurse just knows that they have to do it. That's part of the responsibility of hemodynamic monitoring. So how does the nurse ensure accuracy of the waveform values? Well, to ensure accuracy of the waveform values, the nurse, at the start of their shift or at any time they consider that the values are abnormal, the nurse needs to level the transducer and zero the transducer. What does it mean to level the transducer? Well, that means what reference point to your patient do you want to use? And the reference point for hemodynamic monitoring is going to be the atrium. The atrium is located at the fourth intercostal space mid-chest. And the term is known as the phlebistatic axis. So again, the level of the atrium, the phlebistatic axis, is the fourth intercostal space at mid-thorax. And there are several institutions where I've walked into a room of a patient who has an arterial line, and there is an actual level at the bedside. Sometimes if you're at a private or a for-profit hospital, you might actually see a laser. So however the nurse has to do it, of course, in some hospitals there's nothing, and so the nurse just has to eyeball it. But the bottom line is that you, the nurse, are responsible to ensure accuracy. To ensure accuracy, the transducer has to be level. So you have the transducer on a pole and the transducer has to be level, which means if a physician or another nurse comes in and raises the bed or lowers the bed, you're going to have to either re-level the transducer or you're going to have to move the bed back in its original position. Can the head of the bed be elevated? Yes, it can. You'll still have to find the phlebistatic axis to ensure accuracy. Now, the next thing that has to be done, and again, this should be done at the start of every shift, is zero the transducer. And this is a physics thing. This is basically telling the monitor what is atmosphere, what's air outside, as opposed to what's happening inside the patient. Again, it's very difficult to understand this concept until you see it done in practice. So find a patient with an arterial line or some kind of invasive line and watch the nurse level the transducer and zero the transducer. Now let's talk about another helpful device. Let's say you're the ICU nurse and your patient is coming out of surgery and they've been in the operating room for about 6 hours. And the anesthesiologist is calling you a report telling you that the patient's on their way and that their blood pressure is 70 over 40. So you, the nurse, have to think to yourself, well, what is the cause of that low blood pressure? Why is that patient's blood pressure 70 over 40? And given the scenario, and you know that the patient's been in surgery for 6 hours, you think, well, gosh, it's the obvious reason is that the patient has probably lost a lot of fluids, lost a lot of blood, and they're hypovolemic. Now, what if I told you that then the anesthesiologist said to you that this patient has a past medical history of 2 heart attacks? Now, what are you thinking? Is the cause for the low blood pressure hypovolemia, or has your answer changed? And if you said to yourself, well, wow, it could be that the heart's not pumping very well, well, you're exactly right. So now you have 2 reasons for the low blood pressure. And as healthcare professionals, physicians, and nurses don't want to play the guessing game. Well, I think it's hypovolemia. I think I'll just give 4 liters of fluid. And then, if you were wrong, then you've overloaded the patient and caused possibly their demise. So, we have to take the guesswork out of taking care of critical patients. And to do that, anytime you have a patient whose blood pressure is low or whose blood pressure is abnormal, you have to think, well, what are the ingredients of blood pressure? What could be the causes of a low blood pressure? And we've already identified 2. It could be volume. I say, and of course, for every term that I use, there's always a fancy term. So it could be low volume. So I say volume, I want you to think the fancy term preload. Why? Because Dr. Reed may use these terms in the exam question. And so you have to be able to relate the terms to what the real thinking is. And so if you hear, well, the preload is low, you can just substitute the volume is low. Yes, there's probably a very fancy definition of preload. It's the amount of volume that's available to the ventricle. Well, who cares? It's still volume. Preload, volume. If the preload is high, the volume is high. If the preload is low, the volume is low. The other ingredient of blood pressure is heart rate. Again, if these things don't make sense to you, email me. I've got a nice mathematical calculation which can prove to you that blood pressure is equal to these 4 items that I'm going to talk about. So you just need to know there's 4 ingredients to blood pressure. Preload or volume. Heart rate is also one. Afterload. Afterload, I say afterload, you say resistance. And the last is contractility. Pump. That is the ability of the heart to pump. You can have all the volume in the world and a great heart rate, but if that heart's not pumping, you are not going to have a good blood pressure. And so these 4 things, it's very important for you to remember these 4 things, these 4 ingredients are components of blood pressure. And if you have a patient with a low blood pressure, you've got to consider that it can be one of these 4 or 2 or 3. Very sick patients often have more than one problem. So how can we take the guesswork out of taking care of critically ill patients? Well, a physician can place a pulmonary artery in the patient. Now, are you likely to see this catheter? No, probably not. Unless you're at a facility that does bypass surgery or transplants or very, very critical surgery, because the anesthesiologist will often put these pulmonary artery catheters into patients who are very, very sick. Now, what is the whole point of putting a pulmonary artery catheter? Well, we can get all 4 of those things that we just talked about. We can find out what is the volume status, not only on the left side of the heart, but on the right side on the heart. So both sides of the heart. We can get the volume status of the patient. We can measure the systemic vascular resistance. Of course, anybody can get the heart rate just by taking a pulse. And then we can also get the contractility. So the pulmonary artery catheter takes the guesswork out of managing patients. It will identify what is the specific problem so that the specific problem can be treated. Note that the pulmonary artery catheter is a monitoring device. It is not a cure. It just helps us to take care of the patient better. Now, this catheter, you can see just by looking at it, the pulmonary artery catheter, that it looks complex because it has a lot of ports. And I always say that you need to know about the ports on the Volkswagen model. This is actually a picture of a Cadillac model. It has an extra port that I'm not going to address. You need to know the 4 ports. And we're going to talk about each one with arrows. Again, it's sometimes hard to kind of get the orientation of the catheter, but note that this is the catheter tip. Here's the catheter tip here inside the body, which means this part from about here on out is going to be outside the body. This is what you're going to see, all of these ports, all of these pieces outside the body. This catheter goes through the right atrium, right ventricle, and out into the pulmonary artery, which is why it's called a pulmonary artery catheter. Now, go back to your anatomy. If a catheter goes through the right side of the heart, what must the physician stick to get to, or which blood vessel must the physician stick to get this catheter into the right side of the heart? Your answer should be a vein. So which vein do they stick? Well, they stick a big vein, such as the internal jugular vein, such as the subclavian vein, such as the femoral vein. It doesn't matter which direction they come from. If they're coming from the femoral, they'll go through the inferior vena cava into the right atrium and out into the pulmonary artery. Now, a lot of students ask, well, does this catheter, which looks rather large on the screen, does it interfere with the functioning of the valves? No, it does not. It's actually pretty small, and you can see here it's a better rendition. It's a pretty small catheter. So again, if we did the internal jugular vein or the subclavian vein, the catheter would come in through the superior vena cava and go on through the pathway. The right femoral vein, or left femoral vein for that matter, it all goes back to the right side of the heart, and it would come from the inferior vena cava. Now, what are the ports that we have? Well, conveniently, they are color-coded. So this helps us to identify the space or the location that this port lives in. I say lives in, it's sitting in, resting in, whatever you want to say. It's a port that's in. So let's talk about the blue port first. The blue port. Oops, too many clicks. All right, so here's the blue port. So we have a blue port, and you can see right here this yellow or green circle is the outgoing. This is the hole in the catheter where the fluids, if you had a syringe on this blue port and you push fluid through this blue port, the fluid would come out right here. This is where the hole is. Now, where is that in the body? Well, it's right here. This part of the anatomy of the heart is the right atrium. Now, let's go back to what we learned with the arterial catheter. Totally different catheter. This is pulmonary artery catheter. It's in the vein. It's in the right atrium, but there's a hole. And if there's a hole and I connect the end of this blue port to pressurized tubing that has a transducer on it, that transducer will sense the wave. Again, all blood moves in a waveform. Venous blood, does it move in a waveform? Yes, it does. It's not as strong a wave as in the arterial system, but venous blood moves in a wave. And because it's moving in a wave constantly, then that wave, that ripple, can exit that hole, go up through the tubing to the transducer, and we can measure central venous pressure. Now, I say central venous pressure because that is what it's commonly called. But when I say central venous pressure, I want you always to say right atrial pressure. Right atrial pressure. I say CVP, or you see CVP on a test and you say to yourself right atrial pressure. Why? Well, where's the catheter located, or where's the port located? It's in the right atrium. It's on the right side of the heart. This will be more important as we go through this lesson. So right atrial pressure is the same as central venous pressure. We are measuring the pressure in the right atrium. We are measuring the pressure in the right atrium. Let's talk about another port. This is the yellow port. This port is known as the pulmonary artery port. So in other words, this port, if you had a syringe on the tip of this catheter and you pushed fluid through it, it would go through the catheter down to the tip of the catheter. Now, when this catheter is in the body, where is the tip of the catheter? Well, it's in the pulmonary artery, hence the name pulmonary artery port. So it is in the pulmonary artery. Therefore, if I have pressure tubing connected to the pulmonary artery port, I can measure pulmonary artery pressure. Now, this is where students get confused because I'm telling you it's pulmonary artery pressure. And you think, well, isn't that the same as an arterial line? And I'm going to say to you, no. Remember your pulmonary artery. Your pulmonary artery is what kind of blood? It's deoxygenated blood. It is really a vein. It is a vein, but because it goes away from the heart, whoever invented the names called it a pulmonary artery and therefore confused all of us. But it is really an artery that isn't a vein. It's a vein pretending to be an artery. This is, for all intents and purposes, venous blood, but it's called pulmonary artery. And therefore, because there's a hole at the tip, and because we have this catheter, which you don't see, but you can imagine, connected to pressure tubing that has a transducer, we can measure pulmonary artery pressure. So what have we gotten so far with this catheter? We have measurements for the right atrial pressure, or CVP, and we can measure pulmonary artery pressure. Great, that's two things it can do. Now let's look at the other port. This port right here, this short little red tubing where the syringe is nearby, this is called the balloon inflation port or balloon inflation valve. Whatever you want to call it, you can stick a syringe on this port and you can inflate anywhere between 1 to 1.5 mils of air. 1 to 1.5 mils, never more, of air. What will happen when you push air into the balloon inflation port? The tip of the catheter balloon will inflate. So when you push air in, the balloon at the tip of the catheter will inflate. When you take the air out, the balloon will deflate and your catheter looks like this. So push air in, inflate with balloon, take air out, and now it's deflated. We'll talk more about that in a minute. Next port, one port left, and that's this port here. What is this port? It's called the thermistor or the cardiac output connector. Now, if you were to be able to look at this, you would take this red cap off and you would see prongs. And prongs tells you that you have another piece of equipment that you have to connect this to. And it's another piece of equipment that once the nurse does a little maneuver, then we can measure the cardiac output. So that tells us a lot of information about the heart's ability to pump. We can actually measure the cardiac output, and it will tell us a whole lot about the ability of the heart to pump. So those are the 4 ports that you have to know about on this catheter. There are, again, a lot of Cadillac pulmonary artery catheters. Some have pacemaker wires in them, all kinds of different fancy things. You just need to know these 4 ports. So what we have right now is 2 ports, one that will measure the pulmonary artery pressure, one other port that will measure the right atrial pressure or central venous pressure, a thermistor port that will connect to the cardiac output, and then the balloon inflation port or valve, which will allow us to inflate the balloon at the tip of the catheter. Now, I just talked about some different ports that we have, and therefore, because they are different ports, then they can measure different things. And we talked about the central venous pressure, or I say CVP, you say right atrial pressure. We talk about central venous pressure. We talked about pulmonary artery pressure. Remember that pulmonary artery pressure will be 2 numbers, a pulmonary artery systolic pressure and a pulmonary artery diastolic pressure. So the PAD. Then when the balloon is inflated, we can actually measure the pulmonary artery wedge pressure. When the balloon is deflated, then we are measuring pulmonary artery pressure. So that, again, is where your mind goes, wow, this is confusing. Hang on a minute, and we'll get through some more information, and it will hopefully become more clear. What I want you to get is write these 3 things down. Central venous pressure, pulmonary artery diastolic pressure, and pulmonary artery wedge pressure, or abbreviated PAWP. These 3 pressures tell us about the volume. Now let's do a little exercise in pretend. I want you to consider that you have a paint can. And you have three paint cans actually. And you have three paint cans with various amounts of paint in them. The first paint can is about halfway full. And I put that paint can on your foot. So what do you feel? What do you feel with that paint can on your bare foot? Hopefully you said, well, I feel pressure. And then my next question will be, what do you feel pressure from? What is causing that pressure on your foot? Now, a lot of you will say, well, gravity and the force of the can, and those are all somewhat true. But essentially, you feel pressure because of the weight of the can, and the weight of the can is caused by the volume of its contents. In other words, the amount of paint that's sitting in the can. So you feel pressure from the paint that's in the can. Now let's pretend then I took the paint can off your foot and then I got another paint can that was 100% full, completely full, never been opened, and I put it on your foot. Now what are you going to feel? Hopefully you're going to say to me, I feel more pressure. I feel more pressure because there is more volume in the paint can. More pressure because there's more volume. Pressure equals volume. Now let's take that full paint can off your foot and let's get another paint can that has barely any paint in it. What are you going to feel on your foot? Likely you're going to tell me, I feel less pressure. Less pressure because there's less volume. More pressure, more volume, less pressure, less volume. Pressure equals volume. Now let's go back. Let's go back to our catheter with all of its ports and let's look at each space or each numerical value that you're going to get from that pulmonary artery catheter. And one of the values I said was you're going to get a right atrial pressure, otherwise known as a central venous pressure. And we know that the right atrial pressure is measured in this location. And we know, or we will know, or you now know, that the pressure, the normal right atrial pressure, is 2 to 8 millimeters of mercury. Now, what if I said to you, hey, your very sick patient's right atrial pressure is 15? What do you know? Going back to what we just learned, where pressure equals volume, if I said to you, your patient's right atrial pressure is 15, you would say to me, there is more pressure in the right atrium, and therefore there is more volume. Higher pressure equals more volume. Well, wait a minute. I want you to be more specific. Where is that volume? Well, we're measuring the pressure in the right atrium. Therefore, there is more volume. The CVP was 15. There is more pressure and therefore more volume in the right atrium. Now, some of you might be thinking, hey, that's really handy to have, but what do we really want to know? The atrium is important, but what's more important? The ventricle. If I said to you, your patient has a right atrial pressure of 15, yes, there is probably more volume in the right atrium, but that number really and truly reflects what's happening in the right ventricle. Let me go back to some anatomy. What is the function or what is the job of the ventricle? It is to pump blood forward. Now let's say your patient with a CVP of 15, their right ventricle is very weak and is not pumping blood forward. What's going to happen? Well, their blood is going to basically get stuck right here. More blood. And therefore, just as I have this picture here, just like if you were on a highway and there was a car wreck right here, what's going to happen? Well, blood's going to get backed up, backed up, backed up, backed up, backed up, all the way in the right atrium. Is the blood moving backwards? No, just like when you're in a traffic jam, you're not moving backwards, but you're not moving forward. And that's the key thing for you to get. If the volume is high, then that means that the right ventricle is not moving blood forward. What's the job of the right ventricle? To move blood forward. Does the right ventricle get to choose how much blood it receives? No. If I drank 4 gallons of water, a whole lot of volume would go into my right ventricle because that's what's in my body. And all blood goes through the heart. Whether the ventricle wants to get it or not, it's going to go through it. So therefore, when the CVP or the right atrial pressure is elevated, you can say, I have more volume in my right ventricle, and the right ventricle is not pumping very well. Not pumping very well. Now, you can just say right atrial pressure, right side of the heart. You don't have to go on and say all these things. You just say to yourself, if the CVP is high, if the CVP is 15, there is more volume on the right side of the heart. That's all you need to know. More volume, more pressure. If it's in the CVP, it's on the right side of the heart. Is that important? Well, yeah, because sometimes one side or the other side is not working well, or sometimes it's both sides. You have to figure that out. You have to determine, well, if the volume is high on the right side, then I know for sure that the right ventricle is not pumping well. Grasp that. Then let's move on. Remember, RAP normal is 2 to 8. I have a little cheat sheet at the very last page of the hemodynamic worksheet, and that's something that you can either take to the clinical setting or at the very least put it on your exam sheet. Now let's talk about the review. We have central venous pressure, right atrial pressure. In summary, measurement tells me about the volume on the right side of the heart. Now let's talk about the next value that we're going to get, and that's the pulmonary artery pressure. PAP, pulmonary artery pressure. As with every artery in the body, there is a pulmonary artery systolic pressure and a pulmonary artery diastolic pressure. The normal pulmonary artery systolic pressure is 25. Now, why do I say pulmonary artery systolic pressure, or PAS, is dust? It is dust because we don't use it in this course. You don't have to know about it. Yes, you have to know that when you see PAD or PAP, pulmonary artery pressure, that there is 2 components, a systolic and a diastolic. But you will not be asked about pulmonary artery systolic pressure at all. So I'm not going to go over that. For those inquiring minds that want to know more, that want to do critical care, that want to do cardiology as a nurse, then email me and I'll be happy to answer any question that you have. Pulmonary artery systolic pressure, dust. It exists. Normal is 25. Now let's talk about the one that really matters. The one that really matters is the pulmonary artery diastolic pressure, the PAD. Notice that the pulmonary artery diastolic pressure is 4 to 12. Normal is 4 to 12. What if I said to you, your patient's pulmonary artery diastolic pressure is 2? What do you know? Well, you know that the pressure is low. If the pressure is low, then the volume is low. If the pressure is low, then the volume is low because pressure equals volume. Now, what does the pulmonary artery diastolic tell us about? Where in the heart is the information coming from? Well, it's coming from the left side. So if the pulmonary artery diastolic pressure was low, then that tells me that the volume on the left side of the heart is low. If the pulmonary artery diastolic pressure was 22, the pressure is high, and therefore the volume on the left side of the heart is high. That's what the pulmonary artery diastolic pressure tells me. Again, inquiring minds, email me if you want to know the physics of all of this. But for all of you, with all the information you have to know, the piece that you need to know is what we have so far. The CVP, I say CVP, you say right atrial pressure, tells me about the volume on the right side. Pulmonary artery diastolic pressure, that's a measurement that tells me about the volume on the left side of the heart. Now we have another pressure. And this is the pulmonary artery wedge pressure. Let's look at the picture. Remember we had in the previous one, you could see there's the catheter. And I said to you, when you push 1 to 1.5 mils of air in through that port into the balloon inflation port, then the balloon at the tip of the catheter will inflate. When that balloon is inflated, the catheter will do what's called a wedge. It will wedge in the pulmonary artery. But the very tip of the catheter has a hole, and because there's a hole, I can now measure the pulmonary artery wedge pressure. Look at the pulmonary artery wedge pressure value, 6 to 12. Well, what does this pressure tell me about? It tells me about the volume on the left side. Now, if you're thinking, well, wait a minute, PAD told me about the volume on the left side. You're correct. The left side of the heart is so important. There are two measurements that indicate the volume on the left side of the heart. Now, just because we're doing an extra maneuver, we're inflating a balloon. We're inflating this large balloon in this itty bitty little capillary. Itty bitty little capillary. And so there can be complications with the inflation even when it's done properly. And therefore, because there are potential complications that occur, there are some hospital systems that will not allow nurses to wedge a balloon. If the physician wants the pulmonary artery wedge pressure, they got to trot on up to the unit and measure it themselves. Is it a better pressure measurement? Yes, it's a little bit more accurate than the PAD. However, because the PAD, the pulmonary artery diastolic pressure, and the pulmonary artery wedge pressure both tell us about the volume on the left side, because of the risks of a wedge pressure, then most physicians will simply use the pulmonary artery diastolic pressure. You need to be aware that the pulmonary artery wedge pressure and the pulmonary artery diastolic pressure tell you about the volume on the left side of the heart. So again, where are we at? We are at the fact that the pulmonary artery wedge pressure, the pulmonary artery diastolic pressure tell us about the left side of the heart, the volume on the left side of the heart, and the CVP or the right atrial pressure tell us about the right volume. Now, when we go fancy, I said to you, well, here's the official term of preload, the volume in the ventricle at the end of diastole. Pooh, just say. I say preload, you say volume. CVP, RAP, right volume in the right side of the heart. PAD, PAWP, volume in the left side of the heart. Those two things, three things, you need to remember. Moving on. Let's talk about another function or action that pulmonary artery catheter can perform, and that's the cardiac output. So here's the little device, the end of the catheter. It connects to a cardiac output machine. There's a maneuver that the nurse has to do, and when they do that maneuver, they can measure the cardiac output. The normal cardiac output is 4 to 8 liters per minute. This shouldn't be a surprise. You've had this. So the cardiac output, let's get some terms, because the terms are what throws you guys. So when we have the stroke volume, we say stroke volume is the amount of blood ejected per beat. You know, if the heart has 70 beats, then you take the stroke volume, which say is 70 mils, and then times the heart rate is 70, and you have 4,900 mils or 4 liters, 4.9 liters. So the cardiac output is the amount of blood that is ejected by the heart in 1 minute. Now, normal is 4 to 8 liters per minute, but look at what I have here. We have another value that can be used, and that's the cardiac index. So if I said to you, if I was standing next to Dirk Nowitzki, I'm sure everybody knows who he is. He's over 7 feet tall. I'm 5 feet 1. And I said to you, my cardiac output is 4, and Dirk's cardiac output is 4. And I asked you, is that normal? Well, you would have to say, by definition, that's normal. 4 liters, 4 to 8 liters per minute, so 4 for both of us, that's the normal value. However, size does matter. And therefore, when you use the cardiac index, which just means that the cardiac output has been used in a mathematical equation that adjusts or that takes into consideration height and weight or body surface area, then a calculation will come up with 2.4 to 4 liters. Now, I don't use the cardiac output. I use the cardiac index because it really does tell me more information about that patient. However, you may get the cardiac output or you may get the cardiac index. So you have to know what they each mean, but you can just say that they're both about the cardiac output. It's just that the cardiac index is the cardiac output adjusted for height and weight. Now, if I said to you that my cardiac index is 1.8 and Dirk's is 4, then now you get a better picture that as it's adjusted for height and weight, mine's not so great and his is really good. So that's how we use that. You have to know the values: cardiac output 4 to 8, cardiac output or cardiac index, which is the cardiac output adjusted for height and weight, 2.4 to 4. Now let's talk about afterload. That's our last concept. I say afterload and you say resistance. Afterload resistance. The fancy definition: forces opposing ejection of blood from the ventricle. This is where students, because it's an abstract concept, have the most difficulty with it. When we talk about afterload, we really say, what is the condition or state of the artery? You know that the artery can be a normal diameter, or it can be vasoconstricted, or it can be vasodilated. And so when you think of these terms, you say systemic vascular resistance. This tells you about the systemic arterial afterload. The left I've got systemic arterial BP, and that's not correct. That should say systemic arterial resistance. This left ventricular afterload. The left ventricular afterload. So when we talk about the afterload, we essentially are saying that what is the condition of the artery? Is there more resistance? Is the artery vasoconstricted? Or is there less resistant? Is the artery vasodilated? And these are the things that we consider in afterload. So SVR, the normal systemic vascular resistance, is 800 to 1200. Now you might think to yourself, well, wouldn't we want less is better? No. If you think about muscles and strength, we don't want a floppy muscle. We want there to be some resistance. We don't want there to be too much resistance or too much floppiness. So that's why we want that just right resistance, and that is 8 to 1200. So what does the SVR measurement indicate? It tells the nurse the overall state of the arterial vascular bed, whether it's dilated or constricted. Let's say your patient's SVR was 2200. You can look at the values and you can see, okay, the value is high. And then you can equate that means that the resistance is high. So if the value is high, the resistance is high, the SVR is high, and that means you have a very vasoconstricted systemic vascular bed. If I said to you your patient's SVR was 400, you would say the value is low, the SVR or resistance is low, and the arteries are vasodilated. So it all kind of matches. The terms match. Now, again, because this can be confusing, let's look at it from just a basic standpoint. If you have an SVR, and I said to you, if the SVR is over 1200, then the state of the artery is constricted. So if we go back to what the definition was, and that is the forces opposing ejection of blood from the ventricle, so you think this guy right here is the ventricle. And if the resistance is high, as in the artery is vasoconstricted, what do you notice about the ventricle? What is the workload to the ventricle, well, you know that the workload is greater. And we know that this occurs because there are some conditions that will cause vasoconstriction. And we know that that's helpful to the body, but the side effect of that is that it creates more work for the ventricle. And if you have a weak ventricle to start, then that is really a problem. If it's you or I and we have strong ventricles, it's not so much a problem, especially if it's for, let's say we walk into a cold room. Well, it's not going to hurt our heart if it's sometimes vasoconstricted and the heart has to work a little bit for a little bit of time. So it's not a problem in healthy people, but when it's a chronic state, then it becomes more work for the left ventricle, and the left ventricle can wear out. Now let's do the opposite. If you have a low SVR, the artery is vasodilated. And if it's lower than normal, that means it's markedly vasodilated. And think of it as floppy. It's floppy. There's no resistance, which means then problems can occur. So it means that there's less work. So great. The ventricle's having a great job because it's not having to push its blood out against a big force. However, if it's too floppy, then problems can occur. I hope this has been helpful. If not, or if you're confused, then email me.